Masae Kawamura. Masae. I'm sorry, because what's just written here is L, so I said, Doctor, what does L stand for? It's Loy.
It's Masae.
Masae, sorry for that.
That's okay.
But she said you're not called, they don't call you Loy?
Lois, no, you can just call me Dr. K.
Yeah, Dr. K. Masae. I'm sorry if I
Or Dr.
mispronounce it.
Masae.
Yeah.
Okay. Oh, the music. Thank you very much. Good morning. I hope all of you had a good rest last night and your brain is fresh. I'm going to give you a whirlwind tour because we're starting late and we don't want to overload you with too much information, but I think all of you know how TB and HIV is what they call a global syndemic. It's really changed the epidemiology of TB. They estimate that 1/3 of the world has already TB infection or latent TB infection. So therefore, 1/3 of the people living with HIV and AIDS, the PLWHA, are co-infected with TB. And that's why we have so much HIV TB. And TB is really the leading cause of death in people living with AIDS today, and causes about 1/4 of all the deaths in HIV. And it's quite shocking, huh? You know, that it's a major driver of TB, HIV death. I guess we don't have a pointer today. I can use this. Yeah, you can see. The way HIV really changed our TB epidemiology in the United States, we had a 7% decline from 1950-something, going down every year until the mid-'80s. And you can see that it flattened out, and then you saw this resurgence of TB in the United States, where we have really excellent TB control, but it really went out of control with TB. Thank you. So we did something, right? Because you can see it go down. We'll talk about that a little bit later. But this happened everywhere that had good TB control, where they saw HIV. Okay. So TB and HIV actually have a bidirectional effect. They're bad for each other. Okay. TB increases HIV progression and viral load. Okay. So they often have higher viral loads than someone that doesn't have TB. And when you have TB, the immunosuppression actually accelerates and survival is shorter, even after successful TB treatment. So it shortens the life of the HIV patient. So HIV is bad for TB, TB is bad for HIV. Okay. So the risk of TB, you know, for the average person with TB infection, they say the lifetime risk is 10%. Well, for the HIV positive individual with latent TB, the risk of TB annually is 5 to 10% annually, not lifetime. So if they live long enough, you're guaranteed to get TB. That's not good. And if you're newly infected, I would say the progression rate is much, much higher than 5 to 10% per year from our experience in San Francisco. But ARTs, or antiretroviral therapy, has really changed things. Okay, so not only does it cause quick progression to active disease following infection, but it also increases the risk of reactivation, reinfection, okay, relapse, and also death. And HIV does another thing, okay? So I just talked about the individual. It's really bad for the person who has TB and latent TB. But it's also bad for the public because they are transmitters of disease. I just want to point out, this is a resource center in our Tenderloin, one of the poor parts of our town. A lot of drug users and HIV positive individuals. These green colors are different clusters of TB. They're all from recent transmission, and that's why they have the same genotype. And you see the bubbles that have the red numbers, those are HIV. And so you can see that these clusters are dominated by HIV patients. And they're all, guess what the connection is? this resource center in the Tenderloin. So when TB spreads, they used to think that the HIV patient wasn't a good transmitter of TB. In San Francisco, we just saw the opposite. It was like throwing gasoline on a fire, okay? So it's really, really important, I can't stress enough, to prevent this. And so just like the children that are under 5 who develop TB, you know, they're sentinels of recent transmission, new infection. HIV TB is the same thing. And in Malawi, Africa, there's a study that also showed the same thing, where I just want to point out 72% of the culture-positive cases were clustered, okay? When they're clustered, that means they have the same genotype as somebody else, meaning they got the same they got TB from the same place, so it's an outbreak. If they have a unique strain, then it's from reactivation. So this clustering means that TB in HIV really is caused by recent transmission. So I talked to you about, excuse me, why does that always happen when you're giving a talk, yeah? Okay. So I told you that we had a resurgence of TB, but you can see that we had a very nice decline. So we did something right. So we have some good news. The good news is that TB screening and prevention work. And most of this was using the skin test, okay? So even though the skin test is not so good, we used it, and it's actually quite good in non-BCG vaccinated. Okay, and in San Francisco, this is the program that I ran. We intervened. We had new policies on HIV residential screening. We went and opened a clinic in the Tenderloin, you know, near that resource center that had those big outbreaks. And we treated every latent TB patient with HIV like subclinical TB. We even gave them DOT for prevention. And you can see a really nice decline. Here are the HIV TB cases in red. You see a really nice decline. We had a hard time because we also had homelessness. And in 2005, we implemented mandatory TB screening in our shelters, and that decreased it to the point where now we have only 1 case of HIV TB a year, anywhere between 1 and 5 cases in the city, which is really phenomenal because our HIV rates are so high. Okay, so the bad news is that there's no TB vaccine that works, and there's no HIV vaccine. So we don't have any other option than to prevent TB in these individuals. So I just want to stress to you that serial TB screening, antiretroviral therapy, and latent TB treatment is the standard in the United States. And it's overkill right now because we have so little TB. But we all saw during this epidemic how we could save all of these lives. And it also cut transmission, and that amplified transmission I showed you. So it's really an important intervention for both individuals and the public health. Okay, so what's the rationale for LTBI screening and the treatment? Okay, so I told you that lifetime risk, okay, we already went through this. The lifetime risk for a person who is not HIV positive is 5 to 10%. That's a lifetime. But for the HIV patients, it's anywhere between 5 and 10%. Here, if you're using different data, it's 3 to 10% per year, which is very high. And so the estimated lifetime risk for active TB in the US by a very famous researcher, Bob Horsburgh, is about 20%. And I would guess in the Philippines it would be much higher. Okay. What is the rationale for using antiretroviral therapy, and particularly HAART? Okay. In the U.S., during the era of, okay, so we're looking at TB rates here. when in the era of using just plain old antiretroviral therapy, they saw a decrease in the TB rate by 40%. And with heart, it decreased by 80%. Obviously, in South Africa, the rates of TB was not changed by antiretroviral therapy because they didn't have it back then, but they did implement highly active antiretroviral therapy, and you saw the same kind of decline. So heart is really essential, of course, not only for HIV and other opportunistic infection, or what they call OIs, but for TB as well. So TB, so some HIV docs said, okay, well, if I give them the heart, then I don't need to give them INH, right? Well, what this study shows is that if you give INH only, you reduce your risk by more than half, about 70%, okay? If you give antiretroviral therapy alone, you'll cut your risk in half, okay? And if you give both, then you have an additive effect. But you can see that just giving one or the other alone doesn't completely reduce your risk. So you have to do both, especially in a high transmission zone where HIV patients can get infected again and again and again. Okay, so INH works and ART works, and so that's my message. If you're going to prevent TB, you have to prevent it with both in your patients. Okay, so what does the WHO say? The WHO says, in terms of screening, they advise prevention for all HIV patients in a high prevalence setting, okay, without testing. Okay, I don't know if that would be acceptable here in the Philippines. It's not acceptable in most places. Even in Africa, it's not being implemented because they just don't want to get treatment without knowing they're actually infected. Okay, they have to be asymptomatic as well. And they have the same recommendation for household contacts under the age of 5. So what about the tools you use to screen? Here, WHO does not recommend any tools, but if you are going to use a tool, guess what? WHO said in 2011, and it still holds today, they have a differential recommendation for countries that have TB rates that are over 100 cases per 100,000. You don't use any tests, you just treat, okay? And for countries under that rate, you can use either TST or IGRA, okay? But for those countries who want to use an IGRA, guess what? It says you don't use IGRAs. It's not recommended. It's too costly, and at that time, at 2011, there wasn't enough evidence. But that has changed, okay? They concluded that there was insufficient data, low quality evidence, that you actually, that either the skin test or IGRAs couldn't predict disease, that of course I mentioned the cost, right? So as a public health intervention, it should not be used, okay? So just to get back to the science of things, I want to be really honest with all of you that neither the skin test or IGRA will be fully effective in someone who is immunocompromised. And why is that? Okay? Because the skin test and both interferon gamma release assays are immunoassays, and they rely on cells, antigen-presenting cells like macrophages or dendritic cells, presenting antigen to, guess what? Usually a CD4 cell. Right? And if your CD4 cells are affected by HIV, guess what? You won't be able to produce a very good cell-mediated response. So your skin test, this is your skin test reaction, will be altered, as well as your cytokine release assays being altered as well. Okay. However, where are we today? We are with our IGRA evidence. We really do have sufficient and high quality evidence on IGRA performance in high burden settings in both populations, HIV and children. I showed you a really important breakthrough study showing that QFT is superior to skin tests in predicting disease, that a blood test is certainly more patient-centered than a skin test because you can easily incorporate it into your routine blood testing, and the patients do not have to come back. And in HIV patients, they're notorious for not coming back. And you'll have a lot of cost savings from false positive chest x-rays, medical treatment, and all the side effects associated with false positives. So really, you can actually replace the IGRA with for the skin test. Okay, and it's the most used test now for HIV in Europe and in the US. Our ATS guidelines, they're brand new. They just came out. They are an update from the previous 2000 targeted testing guidelines. I just wanted to point out here that they recognize that the skin tests and IGRAs are not perfect tests. So if you have a very high risk of progression here, you can use either test. And if you want to maximize sensitivity, as you would here, you start off with the most sensitive test, and that would be an IGRA, okay, or a quantiferon. You'd use a quantiferon. But if it's negative, you probably want to do another test just to make sure they're negative. And if both are negative, then you have increased the sensitivity. And if you're negative and the next one is positive, you're going to use that positive as evidence for TB. Okay. So how does it work in HIV children and children with HIV? I showed this study to you yesterday, and this is a study from South Africa with many children, 1,343 children between the 6 months and 15 years. Half of them were, almost half, a little over half were contacts. 507 had no exposure. There was a sizable HIV positive cohort, okay? And you can see the positive rates here. They varied, but they weren't any different. When you get to this level of positivity, you don't see that much difference between the skin test and quantiferon because you actually overcome the BCG effect. So same, I would say the positive rate was same for skin test and quantiferon, but they were different positives, really. The conversion rate was similar as well, 9 to 11%. And the reversion was much less than you see in the United States, 8 to 15%. And this is for the skin test as well. But looking at the sensitivity of cases developing within 3 months, 75% of those cases were detected by the skin test, and they were almost 80% for quantiferon and less for T-spot. Okay? And if you added the two tests together, you got a better sensitivity for active TB. And the best sensitivity was when you added the quantiferon to the T-spot. You got almost a 90% sensitivity for those kids that would progress to active TB. Okay, so this is why the ATS is saying add the two tests together. And in particular, when you have a patient who's a suspect or a high-risk contact that is HIV positive, where you may have false negative. Right? Okay, the other key findings from this study is that the IGRA correlated better to the contact score. So if they had more exposure, same room exposure, et cetera, the IGRAs were more positive than the skin test. But none of these tests were perfect. Each test was negatively impacted by HIV. And 8% of the patients had a positive IGRA and a negative skin test. So how do you interpret that? And the authors said that because the IGRA result was so strong, okay, it argued against a false negative skin test. And this discordant pattern was more common with quantiferon, more exposure, and HIV negative status, okay? So the suggestion is you don't start with a skin test in HIV positive kids or young children. You start with the more sensitive test. You start off with the IGRA. If it's negative, then you would use a skin test. Okay. And in children under age 2, guess what? The IGRA was more strongly associated with the contact score. So, you know, the author did conclude that the IGRAs were better in contacts, including HIV, children, and so that's really important. I just wanted to, I'm going to finish with this because I want Dr. To have a chance to speak and have you ask us questions. But pregnancy. Pregnancy is really important to children, and I'm just going to go straight to this slide here. This is from India, and these are HIV-negative moms, and the background rate for latent TB is about 40%, okay? So this is the positivity on the y-axis, and this is the stage of pregnancy. This is during pregnancy, during delivery, right at delivery, and then 6 months after delivery, postpartum. The black is the skin test. You can see the skin test is only 17%. Quantiferon is 31%. And at delivery, there's no change in the quantiferon, okay? But you see the skin test reactions drop to 11%. And then they come back after they deliver the baby to 25%, not all the way to the background rate, but much higher for quantiferon. So it does make sense, right, that when you're going to deliver a baby, your cell-mediated immunity is reduced because you don't want to reject your child. I mean, that's the way I try to think of it. And this is actually the first evidence that shows pregnancy does reduce the cell-mediated immunity, and perhaps an explanation why pregnant women right around delivery can transmit TB to their babies if they have active disease. There is a second study in India in exclusively HIV-positive moms, and I bring this up because they can transmit TB to their babies. And basically, it's a busy slide. I'm just going to tell you the result, is that it showed the same thing as the HIV negative. So quantiferon was more positive and less impacted by pregnancy than the skin test, but both were depressed during pregnancy and then returned after pregnancy was over in the postpartum period. Okay, but their conclusion was that that the IGRAs were better, and moms developed TB as well, and quantiferon actually detected them. But I just want to end with this slide here, that the testing is not perfect, okay, with either assay, but it is more sensitive than the skin test, and IGRAs have internal controls. IGRAs also are not affected by BCG, and because it's a single visit, it's really much better for the patients that have a hard time coming back. And in HIV clinics, the return rate is usually, guess what, 50% or less, okay? So even if the skin test was more sensitive, there's no way it can be sensitive if you don't come back. So I'm going to just stop here. Do you want me to take some questions now, or we'll go right into Dr. DeCampos's? Okay, great. Let me end my talk. I'll let you end, and then we'll go.